Thank you. So feel free to pitch in your questions and other things on the chat box, and we might come back to that at a later time, but not during the presentation because of the time limitation. The learning objective here, probably the one important learning objective is to have a framework of thinking about substance use disorder in seniors at the end of this presentation, both this presentation as well as the case scenario. Again, still a prevalence of alcohol use is probably the most commonly used substance in seniors. I'm going to skip the epidemiology because that's very self-explanatory. And addiction definition as per the WHO is the repeated use of psychoactive substances, periodically or chronically, chronic intoxication, compulsion, and a great deal of difficulty in voluntarily ceasing or modifying the use. The same thing, and the epidemiology is very fascinating because it seems to be it keeps changing every 5 years in terms of substance use in seniors. And if you look at the last item in this slide deck is the cannabis use by Ontarians aged 50 and older has increased significantly from 1.4% in 1998 to 4.6% in 2000. By no means all of them have cannabis use disorder. It's just the expression of how much prevalent it is, and it might have gone up by if we did the survey now. Again, the most important thing, with aging, there are medical and psychosocial issues which needs to be taken into consideration, especially loss and in different spheres, social isolation, financial issues, associated complex medical and multiple medical problems and multiple medications, mobility issues, sensory deficits, and cognitive impairment. If you look at the entire presentation, some of these themes might keep repeating itself, either in the form of a risk factor or in the form of what we need to take into consideration during assessment, or even screening patients who are at important transitions in their life or in their medical journey, like during hospitalization, coming out of the hospital, changing from housing to independent living to an assisted living or into a care facility. So many of these transition points are important points to screen for substance use issues. Again, substance use disorder DSM-5 guidelines. So these are the criteria for diagnosis of a substance use disorder. So it is very self-explanatory. I'm not going to go into the details of that. Previously, while there were different types of categories like harmful use, intoxication, and other things, the substance use disorder covers mild, moderate, severe under the DSM-5 criteria. It, in fact, simplified the diagnosis a little bit more. But having said that, the single largest caveat is that the DSM-5 diagnostic criteria, you cannot take it and directly apply it to seniors. There are lots of limitations because cognitive impairment can prevent adequate self-monitoring. The entrenched habits of older adults you may not be able to recognize cravings in the same way as a general adult population. And role obligations, which is given a lot of importance in adults with substance use issues, may not be the same in seniors. Again, it takes, because of the physiological changes, the same effect of the substances which they have used comfortably in adult age might have a significant impairment, might cause significant impairment in seniors. Like this, there are a number of limitations to use DSM-5 criteria in seniors. That's one take-home message for today, is do not apply DSM-5 diagnosis as a blanket criteria for diagnosing as a senior with substance use issues. Again, this is what I was talking about. What is that which triggers screening for substance use disorder or substance use? It includes number of physical symptoms screening, which can be a trigger to look at substance use issues. One of the commonest I see in my practice is a sleep problem and cognitive impairment. Other than that, there are a number of other physical symptoms which can trigger, or just to think about substance, could this be a substance use related issue? Again, when you start thinking about assessment, as with any other substance use disorder, it's important to get the full history of substance use as well as medication use, because um, prescription medication abuse could be in itself a substance use issue, which you may or may not recognize until it is too late. Other than that, the usual formats of social family history and all those things you need to cover that. But the other most important aspect of assessment in seniors is basic activities of daily living and instrumental activities of daily living, along with cognitive screening, because we are looking at substance use related to cognitive impairment, or cognitive impairment as a consequence of substance use, which can also have a significant impairment in day-to-day functioning of the individual. Of course, atypical presentations like failure to thrive, loss of interest and motivation, malnutrition should always raise a red flag to talk about substance use. Bottom line is, do not be hesitant or ignore to ask about substance use in seniors, because um, more often than not, now I'm asking about cannabis or cannabinoid products in seniors. I have been detecting more of my patients are trying to get into cannabis medicine and use it for different purposes like pain and other things. Again, this is a follow-up from the previous slide deck about additional warning signs when you have to focus on substance use issues in seniors. This is one of the drug and alcohol treatment guide. This was one of the things, important documents to look at if you have an interest in substance use disorders in seniors. After this, I'm going to focus predominantly based on the CCSMH guidelines on the 4 categories of substance use issues, but still alcohol use seems to be the most prevalent in seniors. And also it's a socially sanctioned behavior, and times it can be very challenging to recognize when somebody is having a significant alcohol use disorder against routine use of alcohol as a part of their lifestyle. Again, drinking is associated or single significant risk factor for hospitalization across the age group, but more so if you look at this graph above the age of 50, it contributes to a significant level of hospitalization. It's still, alcohol is the single most important healthcare expenditure in hospitalized patients. Just a quick case scenario. Mr. DM is a 76-year-old gentleman who lives in a multi-level home with his wife. He presents with 3 episodes of falls in the last 2 months. His wife reports some mild decline in his memory. He has lost 4 kilograms of weight in the last 4 months. He's a retired university professor. He reports drinking 2 glasses of wine every day with dinner. He makes wine at home and using winemaking kit, and has done this since retiring at the age of 65. His drinking pattern increases close to periods like Christmas or Thanksgiving and other times. How many of you think this client is drinking within the safe drinking limit? You can post your response in the chat. We might wait for 5 seconds for that. It is just an option to start thinking about what would be the safe drinking limit as per the guidelines. Again, this is adopted from the guidelines. It talks about what is a standard drink in Canada, and safe drinking guidelines as per the CCSMH guidelines. If you thought this patient is within the safe drinking guidelines, the patient is not within safe drinking guidelines. And for men above the age of 65, no more than 1 to 2 standard drinks per day, but with no more than 7 per week. So the client would have already had 12 to 14. Even if he skips 1 day, it will be 12 to 14 standard drinks in a week. Most of the presentations in substance use disorder will talk about it, because it's important to engrave this as to what is the safe drinking guidelines so that we can advise as well as screen patients. If frail or medically complex, even less than 1 drink per day or none at all is the safest. Again, number of these screening tools have been mentioned in the guidelines. CAGE is the easiest, but SMAST, G, and SAMI, these are, I've included the link for these. You can, if you look at the presentation, you can click on the link. Both these measures can be used for screening. Your practice manager or whoever who can send this to patients to do it. There is an online version as well. So most important thing in substance use disorder management is being aware and start screening at the clients so that you can start giving intervention. Again, treatment recommendations: mild alcohol use disorder, screening, which I talked about, behavioral intervention, which I will have a quick slide deck on that. I will talk about it, and referral for treatment, and giving a patient-centered approach and treatment which is grounded in motivational interviewing. I'm not going to talk about motivational interviewing today because that is usually run as a 2 to 3 hour workshop. But the concepts can be understood easily if you have been doing behavioral health or working in psychiatry for a period of time. You can read about it, and there are online training options available as well. Moderate to severe alcohol use disorder, the guidelines talks about naltrexone camprosate as a pharmacotherapy, which I use quite extensively. And just to make sure that you are aware of the contraindications, because naltrexone is metabolized by liver, and acamprosate has it is specifically prescribed during early abstinence. At the same time, it has got if the kidney functions are affected very significantly, you need to take care of prescribing acamprosate, and it is prescribed 3 times a day. If you look at any alcohol use disorder guidelines in general adult population, then there will be a whole host of anticonvulsants that have been recommended as well: gabapentin, topiramate, sometimes baclofen. So there are a number of alcohol use disorder guidelines by American Psychiatric Association guidelines and other alcohol use disorder guidelines which will recommend that. The CCSMH guidelines do not specifically recommend routinely using any of these medications, mainly because number one, anticonvulsants will be affecting other medications, metabolism of other medications. There are no discrete evidence of these medications, especially trialed in seniors population. And gabapentin, mind you, gabapentin is one of the commonest elements seen in overdose deaths, as well as one of the commonly prescribed medications, which can have some potential for side effects and interactions with other medications when used with other medications that are usually used in seniors. Psychosocial intervention obviously plays a significant component, but when it comes to psychosocial interventions in seniors, outreach support in home and community, home-based detox, and establishing a rapport and slowly building on it and towards either full abstinence or a harm reduction strategy is probably one of the backbones of any substance use management in seniors. Again, a couple of tools for alcohol withdrawal severity assessment. I won't go into this. And to prevent Wernicke's encephalopathy, 200 milligrams of parenteral thiamine IM and or IV administered 3 to 5 days. And there is also a need to continue oral thiamine. The recommendation from different recommendations vary between 100 to 300 milligrams per day oral thiamine. But it's important that oral thiamine can also be continued as long as the patient continues to remain at risk of malnutrition and nutritional deficiencies. There is also a room for managed alcohol taper, as well as home-based detox. I just put up one slide on alcohol-related brain injury. This is not coming out of the guidelines, but alcohol causes brain injury in different aspects. This is my area of special interest, and I've been doing this for a number of years. And I do see patients improving if they become abstinent, and we can intervene in terms of housing, community management, nutritional supplementation, and supports put in place. Again, one, if I were to ask you to remember one of these, probably this slide is very important to think about how to prevent permanent brain damage when somebody is having alcohol use disorder. Um, I'm not particularly going to add a lot in terms of cognitive tools because most of us are familiar with MOCA, MMSE, and adding a little bit of a frontal assessment battery again, which takes about 5 to 10 minutes to assess the frontal lobe functions would be beneficial. As I said, OT and OT based specific functional assessment is also beneficial. I've already talked about this, so I'm going to skip on to the guidelines based on for cannabis use disorder. Again, do not hesitate to ask about cannabis. It is increasing, and it does, cannabis use does have some impact on cognitive functions, cardiovascular disease, cardiac arrhythmias, and coronary artery disease. In terms of medications, as actual prescribed medications, Sativex and Sesamet have, and Nabilone is being trialed for number of indications. One of those includes behavioral and psychological symptoms of dementia as well. Prevalence, I did mention about the increasing prevalence of cannabis, but I was able to pull only the Ontario data. The medical evidence for cannabis is mainly for these indications. Chronic neuropathic pain is still an evolving evidence. There's no overwhelming evidence yet. Nausea and vomiting in chemotherapy, seizures, that too seizures in children. There is not a lot of evidence for seizures in adults. Spasticity in multiple sclerosis and stimulation of appetite. So apart from the chronic neuropathic pain for which CBD component is having evolving evidence, the others are for THC and seizures, not in adults, predominantly in children. That too, it's called intractable seizures in children. Aging brain and cannabis, obviously mobility issues, appetite, cognitive impairment, and arrhythmia. Other than that, it can bring on a number of behavioral symptoms like anxiety, panic, psychosis, and depression. Most important thing, not only to ask about cannabis use, ask about route of administration as well, because it makes a vast difference. That's why edible cannabinoids are not necessarily approved for even recreational use. Edible cannabis does peak of onset between an hour and 3. And if people keep taking it, thinking that they are not having an effect, they can have cumulative cannabis toxic symptoms of cannabis as well. These are a set of cannabis withdrawal symptoms that can happen. And medication treatment, at this point in time, I have put that as an off-label use. There is no one approved medication for medication management for cannabis use disorder. For withdrawal, a whole host of medications like zolpidem, quetiapine, and dronabinol have been used. For cannabis use disorder, dronabinol, nabilone, and gabapentin, and N-acetylcysteine. Having said that, these are not labeled or licensed indication for this. Again, contingency management and motivation enhancement therapy has been indicated as one of the treatment options. Cannabis, sorry, this is a misplaced slide, I think. So a little bit about brief intervention. So we talked about screening, brief intervention, and referral for treatment, SBIRT, one of the repeatedly evaluated approach for substance use disorder. This can be done by anyone and also done at primary care and any other behavioral health setting as well. So the basic steps are understand the patient's views of use. Like, I would like to know more about how many times you are using cannabis in a week, in a day, and what are the aspects you like about this. And they might say it helps me sleep, anxiety, and helps me with pain, and also evaluate pros and cons. And give information and feedback. I mean, is it okay with you if we talk about some of the health risks related to cannabis, because it can cause cognitive impairment, or it can worsen, it can cause falls, and it can interact with some of the medications you take. Best is to Sometimes people don't like talking about it. It's important to have a polite inquiry and ask their permission to do that. And try to take an approach where you can try and use this opportunity to enhance their motivation. Like, given what we have discussed, there are some overwhelming disadvantages or side effects or interactions, um, and help me better understand how do you feel about making a change. I mean, we talked about the understanding, we talked about pros and cons, we talked about permission and then giving information about the adverse effects it's having, and we are talking about on a improving the motivation to change, given that we have given information, and giving advice and negotiating the goal. It's important to have goal setting, and appreciate that they gave an opportunity to talk about something which they are us, we may not have recognized as a problem without having a chat about it. Contrary, it might sound simple, but contrary to what we find as simple, apparently this has got a very significant evidence in multiple settings, including primary care, emergency department, and in terms of transition, like coming to the hospital, getting out of the hospital, seeing the primary care doc, seeing a practice nurse, coming into an assisted living or retirement homes. So it's a very effective tool, and any one of you who is participating here can do this effectively. You don't need a lot of time. Average time it takes about 5 to 10 minutes, it seems. This is out of my recommendation. Just if I have to put one slide deck on medications for different aspects of substance use, these are the ones. I put none in stimulant. For stimulant use disorder, there is no current specific medications that can be used. So whatever is being done is an off-label use. I'll skip the slide. We talked about thiamine. I will skip this slide, but this slide, when you have time, please go through this. This slide talks about exclusions for home detox. So home detox is good. Home detox is encouraged, and an approach which helps many of the seniors. But these are the situations where you don't want to try home detox because of medical complications, and what we would end up needing is a medically assisted withdrawal management. Just a couple of slides left on nicotine dependence. This is a kind of an approach which American Society recommends quite a bit. Ask, advise, assess, assist, and arrange follow-up. Basically, it follows the SBIRT, the short behavioral intervention and referral to treatment kind of approach. So you can use this for everything, or you can use a SBIRT technique for any type of substance use. That is, ask is the screening where you start. Some of the common issues I see with nicotine withdrawal management, I've just taken the patch. This is from the textbook of Principles of Addiction Medicine. And Mayo Clinic has the recommendations as well. If somebody is smoking more than 20 cigarettes a day, prescribing one patch of 14 or 21 milligrams may not be enough. So we may or may not be addressing the craving, because nicotine has one of the strongest craving in substances. So we need to make sure that we prescribe appropriately the patch so that the craving can be addressed. Again, this is a combination therapy. I don't know, how am I doing for time, Lisa?
Well, I sent you a note a few minutes ago. You're just past 22 minutes now, so maybe just a few more minutes.
I'll take 3 more minutes and try to wrap up. So most of these slides that you can read. It's very easy and self-explanatory. Opioid use disorder. Again, I had to recommend you to read this, because this is one kind of a gem in our guidelines in midst of practically very limited substance use disorder guidelines in seniors across the world. Again, one slide I want to, opioid risk tool is an important thing to look at, because many of the seniors might be getting prescriptions of opioids for pain and other things. So have a look at opioid risk tool. At the same time, look for aberrant behaviors. Benzodiazepine use disorder, common in seniors, or probably one of the very challenging situations in seniors. The most important thing I wanted to look at is, this is out of the guidelines, how long it takes to taper benzos. It can, many of my patients who come have been on benzos for a long time. So on an average, it takes about 6 months. And sometimes the last 10% of the dose discontinuation is the most difficult phase of benzodiazepine taper. Again, the one or two differences compared to the adult benzo taper is the routine switching of a short half-life benzos into a long half-life is not routinely recommended according to the CCSMH guidelines, unless there is a significant effect because of alprazolam use. Again, substituting with a different drug, like some people have a practice of using gabapentin and other things, that is also not routinely recommended in seniors. So take time to go through the guidelines, or take time to just go through the recommendations. I think within the first 5 pages, you will read the recommendations and listed. So take time to go through that. But these are the two major differences in adult population benzo taper compared to seniors benzo taper is, do not necessarily change everything to diazepam and clonazepam and taper, or do not necessarily use gabapentin or divalproids trying to taper benzos. So you take your time to taper benzos. Many times it will take 6 months, maybe even more than 6 months. So, but it's important to take the time to do the taper. That's it. Thank you.